Please join me in welcoming to our virtual podium Dr. Joel Phillips. Dr. Phillips is the Medical Director of Supportive Care at Mercy Health Hauenstein Neurosciences in Grand Rapids, Michigan. He is board certified in neurology as well as hospice and palliative care medicine, which makes him a truly unique expert in the field of neuro-palliative care. He completed his medical degree at the Des Moines University Osteopathic Medical Center, followed by a neurology residency at Henry Ford Hospital and his fellowship with Grand Rapids Medical Education Partners. Dr. Phillips describes his philosophy as providing treatment consistent with patients' wishes regarding care. Often this involves explaining different courses of action and including input from other healthcare providers. Ultimately, to individualize the care pathway to meet each patient's needs. Apart from his medical practice, Dr. Phillips enjoys spending time with his family, hiking, fishing, and getting out to Lake Michigan as often as possible. Welcome, Dr. Phillips.
Well, hello, and first of all, I want to thank everybody for this opportunity to come here today and talk to you guys a little bit more. Especially, I want to thank Alicia for getting all of this coordinated for us. It's a great thing that we can be doing, and I wanted to spend some time today talking to you about a new type of medicine called Neuro-palliative medicine. My name is Dr. Joel Phillips. I work at the Hauenstein Neuroscience Center at St. Mary's. I'm a neurologist with some palliative medicine training and wanted to go over, kind of introduce you to this new topic. So as we go over things today, here's a brief outline. First of all, I want to talk about what is it like to get that diagnosis of myasthenia and what can be going through your head at that time of new diagnosis and a kind of a life-changing event. Then I want to go into what is palliative care, try to describe that a little bit more for you, and then talk more specifically about what palliative care is in neurology. Oftentimes the question comes up, when should I see palliative care and what would be an appropriate time to do that? And then finally, I want to talk about some local neuro-palliative care services here in Michigan. So we'll start with getting the diagnosis. This is something that many of you have experienced. You started to have symptoms, maybe some muscle fatigue, changes in vision or difficulty speaking, difficulty breathing. You saw your neurologist, got some tests run, and then you were given this diagnosis of Myasthenia Gravis. And sometimes that's what sticks, is that diagnosis. And your neurologist or your doctor might go on to give a lot more terminology as well. Some of the terminology may be new, some of it may be some things you have heard before, but oftentimes a lot is thrown at you all at once. Maybe new labs that need to be checked or new tests that need to be run, or what does treatment even look like? And so all of this is thrown at you, and things are going through your head. Like, how does this change me? What does this mean? What is life going to look like with this diagnosis of myasthenia? How do I plan for the future, and what does that future look like? What is treatment like? How do I keep things normal? And will my family be okay? What really lies ahead? And then how do I tell family? How do I tell friends? This is going to be a major life-changing event for me. How do I process that? And it can take several days, even after getting the diagnosis, to really work through that. And that's where our job comes in, to really integrate the perspective that you and your family come in with to that of the medical perspective. So you come in with your life as you know it up until this point. You got your job, your family, your friends, your hobbies, your likes, your dislikes. And then we come in with our medical perspective, and we've got that language, that terminology again, all those labs, all those tests, things that need to be done for you to kind of figure out what the next steps are and how to treat you the best. Our first job as palliative medicine really is to bring those perspectives together, bring that understanding in relevant terms of the impact of myasthenia gravis in that day-to-day life, and how can we really make things work for you so that you can continue living as well as you can despite this new diagnosis. So that brings me to the big question of what is palliative care? And if you don't remember anything else from today, this is what I really want you to walk away with is palliative care essentially means supportive care for living well. So that can take on different sort of forms, can take on different sort of meaning. but it really boils down to supportive care. So I want to dig into that a little deeper here. This is the definition from the World Health Organization. It states, an approach that improves the quality of life for patients and their families. And I want to point that out, that families are involved in this as well. Myasthenia and other neurologic conditions really do affect not only the patient, but family and friends as well. So it's an approach that improves quality of life for patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering, early identification, and impeccable assessment and treatment of pain and other problems, physical, psychological, psychosocial, and spiritual. So often when people hear palliative care, they think, oh, that's for pain, but it goes beyond just pain, but really wants to address all physical symptoms, psychosocial and spiritual aspects that go into any sort of disease process or neurologic condition. So another way of putting it, the palliative care's primary goal is to improve quality of life, ensuring patients find meaning and value in the setting of a life-limiting disease. And again, it provides care for the whole person through the physical, emotional, and spiritual aspects. And palliative care accomplishes this through a few different ways, and you may see some repeated themes as we go through here. One of those is aggressive symptom management. Symptoms can be quite severe and even debilitating, so we want to make sure we keep those under the best control we can. Sometimes it means we need to improve functionality. When possible, get in adaptive devices, other sort of medical technology that can help. Oftentimes physical therapy or occupational therapy may be part of that mix. Often we talk about advanced care planning and what does that future look like? What can I expect down the road? And what sort of decisions might I have to face going forward? And then importantly, we also assess caregiver needs. Myasthenia, again, can affect the whole family, and we want to make sure that everybody involved in your care is well supported. And this really does take a team approach. So it's not just the physician, but it also involves physical therapy, occupational therapy, even speech therapy, and even respiratory therapists. Oftentimes, physical therapy has extra nurses, social workers, and even chaplains to help work through a lot of these different issues that may arise. So one of the questions I get a lot when people hear palliative care, this is the question that comes to mind. Isn't palliative care hospice? And I want to answer that by saying, well, not really. There's a relationship, but I want to explain that with this diagram to kind of show you why we've got that sense that hospice and palliative care are equal, and they really aren't. If you look at this diagram here, that outer circle here, I'm going to point to it, is really the whole realm of medicine. So we're talking about your primary care doctor, nurses, any sort of specialty that can be involved. But then we look at this inner circle, which is a specialty within medicine. In this case, I'm using the example of gastrointestinal. So you move from the broader spectrum of medicine to focus on one specific area like gastrointestinal from the mouth down to the rectum. But even in that, we can focus further and we can have subspecialties where there's doctors who just focus on treating the liver, hepatologists. And each step we're getting deeper and deeper, moving from that broader sort of circle lower and lower and more focused. Where palliative care and hospice is different is palliative care started with the hospice movement. So it started with a subspecialty and worked outwards into more of a specialty of palliative care. So hospice started and then kind of grew and expanded. And now we actually have several other subspecialties in palliative care. These include palliative oncology, palliative neurology, cardiology, and even physical medicine and rehab. So palliative care just in the last 10 or 15 years has really broadened its perspective and its scope and can be available to help patients at any stage of the disease. A little bit of background on that and how we kind of started from hospice and moved forward to palliative care. Historically, palliative medicine began with the hospice movement, as we talked about. Dame Cicely Saunders was a nurse in England who looked at the healthcare system and said, we can be doing so much more for our patients. So she actually went back to school to become a social worker Did that for a while, but said, I really can change the system even more. And she went back to school again to become a physician. And once she was a doctor, she founded St. Christopher's Hospice in England. And that was back in 1967. And her whole focus was to provide pain and symptom management with a holistic approach, addressing all of patients' needs, from the physical to the social, psychological, and spiritual again. And she actually coined the term total pain. And that really refers to the fact that pain itself, one physical system, can be affected by all these other needs, psychosocial, spiritual, and emotional as well. So she really took a different approach to look at the whole person in order to manage the symptoms and the conditions that they were in. So what does that mean for palliative care? I want to kind of go over a few of the differences between palliative care and hospice. Palliative care, as we talked about, is provided regardless of the disease. You can be at any stage in the disease, and it's regardless of life expectancy. The setting of palliative care, it can take place in the hospital, and most hospitals around the country do have inpatient palliative care services addressing symptoms and needs as they arise while patients are admitted. But more so, we're starting to see outpatient palliative care clinics form where patients can come to the clinic to talk about more chronic and ongoing processes that can be better addressed right in the office. Where hospice differs is it's palliative care at the end of life. Usually by Medicare or Medicaid guidelines, a physician has to say that the prognosis for that patient is 6 months or less. So that kind of gives us more of that terminal stage where hospice would come in and be appropriate for patients. One of the bigger differences is that hospice goes to the patient. So rather than a patient coming into the clinic, hospice goes to wherever that patient is, whether it be at home, in a nursing home, assisted living facility, and sometimes it does even come into the hospital to help with patients who are at the very end stages. There are also standalone hospices that can treat patients as if they were in the hospital and have that sort of same inpatient sort of setting. So now I want to look closer at what is palliative care in neurology specifically. And all through my training as a neurology resident, my neurology mentors and faculty would ask me essentially the same question. And that question was, I'm a neurologist. All I do is palliative care. Why do I need to go into extra training for that? And what they were essentially saying is this. There's no cure for many chronic neurologic diseases. What I'm doing is symptom management. You don't need extra training for that. And I want to address that and kind of say, there's a little bit of truth in that. What neurologists do can be seen as palliative medicine. But to better understand what neurologists do specifically and then what palliative medicine can do, I want to look at two different terms here. The first one is primary palliative care, and the second is specialty palliative care. So looking first at primary palliative care, this is palliative care that doctors, nurses, and support staff are all providing regardless of the level of training. What we're doing as neurologists in general is enhancing quality of life. We have symptom management and we discuss treatment options. So in a sense, all neurologists are already providing primary palliative care. So if you didn't know it already, you're already receiving palliative care. So I want you to kind of take that away and know that this is already part. So it doesn't have to be a big, scary term, but it's something that we want to make sure you're getting no matter what. Primary care, specifically in myasthenia, can look like medications and treatments like Mestinon or pyridostigmine, the plasmapheresis or IVIG you may be receiving, immunosuppressants, corrective lenses for visual problems, and supportive services you might already be getting, physical therapy, occupational therapy, and even respiratory therapy. What specialty palliative care can do is provide that next level of care. What it is it comes into the scene when there's specific complexity to a case. There's symptoms that are difficult to manage. There may be more complex life situations, living at home or social situations that are impacting your care and how well care can be received. And then there can be more existential and spiritual suffering as well, which the palliative care team can help better to address. And so what really is that role of palliative care when it comes to these neurologic conditions? One of my mentors had best put it this way. It's like a three-legged stool, where up here at the top is really the patient, and we want to provide that support for patients. So that support comes in three ways. First is through community and support groups, events like these, ways to get you information and the support that you need. The next is through primary care physicians, neurologists that you're already seeing to help manage that myasthenia or other neurologic conditions. And third really is through palliative care specialists to take a different look, kind of with that 10,000 foot view, to make sure that what's going on is really consistent with what you want. When we look at timing of palliative care, what I really mean here is at different stages in any sort of condition, the palliative care might look a little bit different. So we talked a little bit already about that early diagnosis with integrating those two perspectives between who you are and what you come with and what those medical perspectives and expectations may be. So early on, we can provide a lot of this emotional support. It really is a particularly challenging period of time, and there's a lot of questions that can be asked and should be asked, and we want to make sure you have the answers to those. Kind of middle stages, we're talking more about goals of care and symptoms. We want to make sure that all symptoms are addressed, and we want to see that going forward, we want to make sure that what you want to have happens gets accomplished. And in later stages, and this may be more so for Parkinson's disease or ALS, but there are times when we need to start talking about transitions to hospice, and there are appropriate times for that, and we can help walk through those sort of situations as well. So I want to talk a little bit more about symptoms as well. What research has been showing in the recent years is actually that patients with neurologic conditions do have a very similar symptom burden to those patients with metastatic cancer or advanced cancer. So there can be a lot of stress or depression, spiritual well-being issues, cognitive impairment, difficulty with swallowing, both with aspiration, where food may accidentally go down into the airway causing pneumonia, versus poor nutrition because we're not getting enough calories in. Excessive secretions can also be a problem when we have some difficulty swallowing. It may be more difficult to manage saliva and that sort of thing. Fatigue is also a major player in a lot of chronic neurologic conditions. So beyond symptoms, again, I've mentioned it before, we want to assess the spiritual and psychosocial needs. There are a lot of difficult transitions to this new role of how do I live my life with myasthenia and what does that look like for me? We want to get chaplains involved when that would be appropriate. Social work can also help with that. But we also want to help caregivers and provide support for caregivers. Oftentimes caregivers may have feelings of responsibility for their loved ones, and they're doing a great job of caring for them, but can get tired, fatigued themselves, and feel some guilt over wanting a break or some respite from that care sometimes. So we have social workers within our team who can help caregivers as well, provide them with the resources that they need, and help them get that respite that they would need. And finally, we can also talk about advanced care planning. This is where we start talking more about interventions and treatments that match what you would want as the patient. So there's a lot that can be done, but we only want to be offering or providing things that should be done in your specific care. And I want to go into that a little bit more detail here with advanced care planning. When we talk about advanced care planning, oftentimes the conversation tends towards end of life or more advanced illness. There are some things that may need to be addressed that are not necessarily end of life issues, but one patient put it very well. This patient is with muscular dystrophy, and he put it this way: let's talk about the end of life, then get on with living a good life. And what he was basically saying is discussing the future helps us live better today. So rather than worry or fear or not talking about the elephant in the room, let's talk about it, get some plans in place, but then we can move on and continue living our lives as we should. Another way of putting that is addressing issues before they become issues, meaning sometimes there's interventions that may be appropriate in emergency situations, and we'd rather have talked about those those issues or those treatments now, rather than getting into that emergency situation and having to make a panicked decision at that moment. Part of what we do when we talk about that is we discuss prognostication. We can't predict what's going to happen, but we do have certain patterns, and we do know that certain diseases and conditions follow these certain patterns. So it can kind of give us a way to plan and anticipate what may be coming down the road. So what to watch for, and then even life expectancy. And sometimes, as with myasthenia, my life expectancy may be more normal. There are other conditions where we do expect it to cause a shortened life expectancy, but those are all things we want to talk about. With advanced care planning, we also talk about these future treatment options. What's available as far as medications? What sort of equipment is there? What sort of things are there going to be to help you function the best you can? And again, what about those emergency interventions, such as feeding tubes or CPR or invasive mechanical ventilation? And finally, advanced directives themselves are also called living will. This is the actual paperwork that goes along with advanced care planning. And what these specifically address are some of those issues like CPR and mechanical mechanical ventilation. What should I do if my heart were to stop? What sort of treatments would I want? Or would I say, no, thank you, I don't want that? Advanced directives also talk about a durable power of attorney, or a DPOA. And I want to talk specifically about what that looks like just while I have you guys here today. Before we get into that, the advanced directives themselves, as I said, are a document, that living will, which name that surrogate decision maker, or that DPOA, and list those medical preferences that you may have when you can no longer make choices for yourself. In the state of Michigan specifically, these must be signed by the patient. So it has to be something that you fill out and name that person to be your decision maker. And then you need 2 witnesses to sign it. And these cannot be medical professionals or family members. People usually use friends or neighbors for this. And then finally, that person who is going to be your power of attorney signs the paperwork as well, saying, yes, I accept this responsibility to make decisions on your behalf if you no longer can do so. So what does that power of attorney look like? It is, again, that designated surrogate medical decision maker. It's named in the advanced directives and must be chosen by the patient. So this is something that you specifically choose, and you choose that person. The power of attorney only becomes activated when 2 physicians do an exam and say that you no longer have that power to make medical decisions. You no longer have that capacity to do so. Without a power of attorney in the state of Michigan, if you can't make decisions, it defaults to all first-degree relatives. So any adult children, mom, dad, brothers, sisters. So it can be a lot of people that have to come together and make a unanimous decision. So that's why I encourage a lot of people to get that power of attorney named, just so you don't have so many people trying to figure out what's going to go on in your care. A power of attorney differs from a legal guardian. A legal guardian, again, is a designated surrogate decision maker, but this is appointed by the court and not by the patient. It's given to patients when they lack competency to make medical decisions, and it's designated for a patient when a patient has not previously completed that power of attorney. And this whole process can take several weeks. So that may be several weeks where we're kind of sitting in limbo trying to figure out who should be making these decisions and how do we get that done? So that being said, when should I see neuro-palliative care? What's an appropriate time? Because it's such a new field, there's no specific guidelines as to what would be a good time to do it. But if there's any sort of distressing or complex symptoms that you think need better management, it may be good to call in palliative care to help with some of that. Recently, there has been some recognition that early involvement may be better. Because with early involvement, we can develop that roadmap to better navigate care. We can anticipate what's coming down the road again, and we can talk about all of these things to make the best plans for you. Complex symptoms may be present right from the beginning of the diagnosis. So it's good to have somebody there who can help you with that symptom management. And as things progress, if there's advancement into illness or we need to make transitions to higher levels of care, these transitions can be smoother if you've got palliative care already working with you. You've already started to talk about these things. You know who this person is, this new doctor who wants to help make these decisions, rather than jumping in cold in again, a life-threatening or more of an emergent situation. You've already kind of established and you kind of know who each other are. That being said, cancer populations, there's been evidence that palliative care along with radiation therapy or with chemotherapy has really shown to improve survival rates and improve overall quality of life. So already in the cancer world, we see palliative care getting involved right from the onset of diagnosis. So it really becomes more of a partnership working with your current neurologist to really figure out the best things for you. So now I do want to talk about palliative care specifically in myasthenia gravis and what that might look like for you and your family. I wanted to include this slide to really show what's been happening with myasthenia over the past 100 years. This is a graph showing mortality or kind of what the percentage of death by myasthenia is in patients who are diagnosed with it. 100 years ago, you can see that was mortality rate of 80%. That's about 4 in 5 patients with myasthenia would die because of myasthenia. Through the last century, as we've gotten new medical advancements, we've recognized the different receptors. We've gotten better at mechanical ventilation and providing some of this respiratory support. And also with the new treatments like IVIG and plasmapheresis, we've really taken that mortality rate and gotten it down to close to under 10%. So it's really not the life-threatening illness that it once was, which is great, but there's still potential for emergencies and crises that would potentiate more of a life-threatening situation. And so specifically in myasthenia gravis, what can we do for you? At diagnosis, again, there may be further questions or unique circumstances surrounding your treatment, specific preferences that you say, you know, I'd like this, but I really don't want this, or maybe there's something going on at home that would really affect your ability to come into to get treatments like infusions or things like that. And these options can be discussed both with your neurologist, but sometimes kind of taking a look at the bigger picture with palliative care can be helpful. Through the course of myasthenia, again, there may be difficult to treat symptoms, either early on, middle, or even as we're reaching more of that remission stage. At any point, those symptoms can be addressed. And then again, it becomes very important to discuss advanced care planning. And specifically with myasthenia, we all face the myasthenic crisis. This is something you guys may be familiar with or have talked about in the past, so I want to just briefly cover it here. But knowing what this is can help you better fill out your advanced directives or have a better plan for what's going to happen. So myasthenic crisis itself is severe weakness of the breathing muscles. Oftentimes it requires hospitalization and mechanical ventilation support while we're waiting for your muscles to kind of regain strength. And it could be a prolonged time in the ICU, 10 or 12 days with a long time in rehab after that. These crises can be triggered by several different things. They can be triggered by infection, by surgery, even certain medications. And those lists are widely available of what ones to avoid. But sometimes these things happen, and we want to know how best to treat it if it were to happen to you, because these do become life-threatening situations if they're not treated. So knowing about this and planning for it going forward can be very helpful to help kind of just in that day-to-day life and say, you know what, I got a plan if that happens. Kind of helps put your mind at ease. So specifically with advanced care planning in myasthenia, what should we do in a myasthenic crisis? What interventions are acceptable to you? If you are ventilated, how long should you be ventilated for? Is that something we should do it for a short trial period? Or is it something that you'd be willing to do on more of a long-term basis, weeks or months at a time? And if that's the case, there's different procedures that would need to be done to allow that to happen. So these are some of those interventions again. Feeding tubes. What does it look like to get food and nutrition in if you're having difficulty breathing and you can't swallow because you're on a ventilator? What do home breathing machines look like? In certain cases, even outside the hospital, because of the muscle weakness that's there, a lot of patients may need breathing machines or non-invasive ventilation at some point in the course of the myasthenia. And even feeding tubes are something that can be managed at home if there is that difficulty swallowing as part of the natural course of myasthenia. And so finally, I wanted to talk about neuro-palliative care in Michigan. And I use Michigan because last I checked, there are only 3 neurologists in the state who are board certified in hospice and palliative medicine. And of those 3, our clinic here in Grand Rapids is the only active neuro-palliative care clinic. So as great as it is, or as helpful as it is, it's rare. It's a new and growing field, and I hope to have more neurologists go into the field in the future. But right now, there's not many of us. There's only about 144 nationwide. So that being said, I want to be able to help in whatever way I can for whatever patients that need it. So at St. Mary's, we are available to patients with any chronic neurologic disease. So that could be Parkinson's or multiple sclerosis, dementia, or even myasthenia gravis as well. We address a lot of things that we talked about today: education and support, complex symptom management, advanced care planning, and then transitions to care at the end of life when those discussions are appropriate to be having. The goal, again, is really to work alongside your primary neurologist. So it's that same idea of that 3-legged stool again. So we want to be there to support you while you still have your specific neuromuscular doctor who is managing your infusions or your medications or the day-to-day management of the myasthenia. Our role can look different for different patients and at different stages. Sometimes it's an as-needed consult where there's one specific symptom going on that we really need to get addressed, and it might be just a one-time referral. It might be more of something I term co-management, meaning that it's that partnership again, where you still see your primary neurologist, but then you see palliative care at the same time. And you would kind of see both neurologists more intermittently walking through the course of myasthenia. Sometimes with advanced cases of neurologic conditions, that co-management may go on for a while, but eventually your neurologist, either your neuromuscular doctor for conditions like ALS or your movement disorder, if your conditions are more like Parkinson's, those medications that they can offer, the treatments that they can offer, cannot stave off the progression long term. And when we get to that point, often we talk about a transition of care to neuro-palliative medicine as more of your primary neurologist to take over care and talk about more of those advanced stage sort of symptoms, complex management again, and even those transitions to end of life or hospice when appropriate. And even when patients do enter hospice, neuro-palliative care can still be there to help those hospice doctors and really address those neurology-specific sort of problems that can arise. So as we go through that process, neuro-palliative care is there to walk through you through diagnosis all the way to the end of the disease, whatever that may look like. And it may be intermittent and different throughout the course, but we're there for you throughout the whole thing. Inpatient neuro-palliative care does exist as well, and specifically at our organization, it's integrated more into the general palliative care team. So we'll see patients with acute neurologic admissions for myasthenic crisis, for stroke, for seizures specifically, and address the things that come up along the way. If patients come in who have other progressive neurologic disease, myasthenia or Parkinson's, but are here because of something else like pneumonia or infection, palliative care is there to take into account the other underlying conditions to help treat you better for whatever those underlying or those reasons that you're admitted for are here. And in this case, patients may be seen by myself with neuro-palliative care, but may also be seen by other members of the palliative care team. With that said, I wanted to take this time to briefly review a little bit about what palliative care is again. Palliative care really is that supportive care to help living well no matter what your neurologic condition is, really to improve functionality, improve support for yourself, for your family members, so that you can live as well as you can despite myasthenia itself. I do welcome any questions. I have my email up here. If anything comes up, I'm happy to answer those questions for you. And I want to thank you guys again for this opportunity.
Thank you, Dr. Phillips, for your amazing information on palliative care for myasthenia gravis. If you found value in this information, please consider a donation to the Myasthenia Gravis Foundation of Michigan. Your donation helps ensure that we can continue to offer this important info to our MG family going forward. You can donate by texting MGMI to 41444 or by visiting our website, mg-mi.org. Please join us this evening at 6:30 p.m. Eastern Time for a discussion on MG in the eyes with neuro-ophthalmologist Dr. Christopher Glisson. We look forward to seeing you there.